IIH is a condition that is characterized by increased intracranial pressure without a detectable cause.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Hadi Saheb and myself, Heather O'Donnell. Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien. We will be sharing our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers.
Dr. Neufeld obtained her undergraduate degree at Simon Fraser University with a joint major in molecular biology, biochemistry, and business administration. She received her medical degree from the University of British Columbia and completed her ophthalmology residency at Dalhousie University. She was then accepted into a fellowship program in neuro-ophthalmology at the Moran Eye Center at the University of Utah. Dr. Neufeld joined neuro-ophthalmology faculty at University of British Columbia in 2017. Her current practice combines academic neuro-ophthalmology with a surgical comprehensive practice. Dr. Neufeld is an active teacher. She regularly participates in giving lectures in ophthalmology to general practitioners and optometrists. She teaches medical students, residents, and fellows as part of her position as a clinical assistant professor at the University of British Columbia. She also holds an adjunct assistant professor position at the University of Utah. She's also recently taken on a role of regional medical lead, implementing clinical curriculum for a new Simon Fraser University School of Medicine. Dr. Neufeld, welcome to EyeCan. I am so looking forward to our conversation tonight. Thank you so much for joining us.
Thank you so much, Dr. O'Donnell. What a pleasure it is to be here and talking to you about some of the more common conditions that we see in neuro-ophthalmology.
This evening, what we want to talk about on today's podcast is we want to talk about idiopathic intracranial hypertension. And before we launch in and start asking you questions, I just want to say that when I see patients with this condition, having had a bunch of training in residency, I feel like there's been this long gap in my knowledge where because, I'm not out at Nanos with the other neuro-ophthalmologists, there's lots of things that have probably changed and happened. So I was really excited about this podcast so that we can get not just me up to date. I know I'm going to learn a lot tonight, but so that for our listeners, they can utilize this also as an education tool, which I'm so excited about. So thank you for coming and being here and talking about this topic that's so important to so many of our neuro-ophthalmology patients.
Oh, thanks, Heather. I just wanted to mention that this topic is very near and dear to my heart as well. As a resident, when I started in ophthalmology, this was my first research project that I worked on with the team at Dalhousie University, which was researching venous sinus stenosis in these patients, which was just sort of a newly discovered field and finding in this condition. So it really takes me full circle from starting in residency, working on this condition in research, and then now talking about the most recent advances. And so I'm very excited for our discussion tonight.
So good. So why don't you set the stage for us? Tell us about what is IIH.
Before we talk about the condition itself and the nitty-gritty details, I would like to address the nomenclature of the condition. Some of the listeners and some of the ophthalmologists who trained years ago may remember that we call this condition pseudotumor cerebri. It might still creep in some of the literature and the older papers that we see. We used the terminology in the 60s when this condition was defined, and really it was to refer to the fact that this condition behaves very much like a brain tumor. And of course, the pseudo refers to the fact that it isn't a brain tumor, but behaves like one. And it was used to define the condition as we understood it at the time. Next, the term that then began to be used a few decades later was a term called benign intracranial hypertension. And as you may appreciate, benign is not really a term that we would appropriately use to define or describe this condition. It is by far not a benign condition. It can cause significant disabling symptoms with headaches and pain, as well as, of course, vision loss, which is so near and dear and important to us. Some of my colleagues like describing IIH, this condition that we're talking about, as primary intracranial hypertension, because that actually more refers to the etiology of the condition versus secondary intracranial hypertension. But really,
Oh,
yeah,
okay.
but really the universally accepted term now is idiopathic intracranial hypertension, which you will see in the literature these days.
Oh, that's such a good update. Okay, so tell us, what is this condition and who gets it?
IIH is a condition that is characterized by increased intracranial pressure without a detectable cause. So we'll talk a little bit later and we'll get into the details about what other causes there are that mimic this condition. But it's really important to understand when we use the term IIH or idiopathic intracranial hypertension, it refers specifically to a condition that is without a detectable cause. The incidence of this condition is about 1 in 100,000 in the general population. So we do see it, especially as a neuro-ophthalmologist, I see it frequently. And specifically, if you look at a subset of our population and the patients that, obese population, it's about 20 in 100,000, which actually, if you look at other common diseases that we think about, like MS, about the same incidence. As you know, the general public is a lot more familiar with multiple sclerosis than IIH, and we hope to
Totally.
change that as we educate everybody about this condition.
No kidding. Yeah, that's very interesting. I didn't realize. I think that's a very helpful parallel. And before we move on, because I know you want to talk more about it, but what is like when you say intracranial hypertension, for most of our listeners are kind of ophthalmologists, ophthalmology trainees, but we do have some listeners that are general practitioners or the lay public. So what does it mean to have intracranial hypertension?
It's a great question. So I think that before we talk about what that means, I think it's important to talk about understanding sort of the pathophysiology and how CSF or cerebrospinal fluid or spinal fluid is made in the brain and the body. So let's take a step back, and to understand the pathophysiology, one must review how the CSF is produced and drained. So to review, CSF is produced in the choroid plexus in the ventricles of the brain. The CSF is cleared through the arachnoid granulations, as well as some of the brain lymphatics. Some is drained through the cranial nerves and foramina in the brain. And there's a new concept, which you may not have heard of before. It's a concept of glymphatics. Have you heard of that before? Or?
I have not heard of glymphatics. I sort of feel like this is like are you sure this isn't like a Gen Z version of lymphatics or something? This is like a,
Oh, we've all heard about
like
lymphatic
this is
massage.
lymphatics with Riz. This is,
Yeah, we've all heard about lymphatics massages, and I wish it was as simple treating this condition as a lymphatic massage. But so glymphatics specifically refers to a brain's waste clearance pathway that basically uses CSF fluid to remove metabolic waste and toxins from the brain. And it's the location of the glymphatics, as we refer to it, is the perivascular and peривascular channels. They're not actual lymphatic vessels, but they're rather sort of the interstitium in between vessels that drains the CSF as well. So all of this sort of incorporates into how the CSF is drained, and the hormonal changes in the body can impact how the CSF is drained. So when somebody thinks about IIH, you must think about three main concepts. So number one is metabolic and cardiovascular health abnormalities in the patient. So the examples of that would be, and we're learning more about this now, is something called leptin resistance, for example. We've all heard about insulin resistance, right? It's a very sort of catchy term that we're using these days in terms of metabolic health. Leptin is a signaling molecule that travels through the bloodstream to the brain's hypothalamus to signal satiety. And we know patients with IIH have this resistance to leptin, as they often have insulin resistance as well. And this is all set on the background of inflammatory markers and changes, oxygen saturation issues with sleep apnea, and conditions like PCOS, which all kind of fall into this bucket that impacts this condition. And then the second concept to understand is the fact that there are structural abnormalities that we see in the brain. And specifically, I'm referring to venous sinus stenosis, which can impact the drainage of CSF and create a predisposition to this condition. And then the third concept is is the abdominal adipose tissue, where a lot of hormonal work happens specifically in females, which can contribute to this condition. So basically, the concept is CSF production is increased, and that's usually done via multiple hormonal signals like increased cortisol or ATPase activity in the choroid plexus that causes raised intracranial pressure. But in addition to that, there is an issue with CSF clearance with these patients. That's due to venous outflow resistance and these lymphatic dysfunction that we talked about, as well as inflammatory changes. And things like androgen axis, for example, and it all sort of centers around the setting of metabolic disease with central adiposity in females. So a very complex system. And what I really want to stress is that we cannot think about IH as a linear condition. And primitive thinking about this condition was very much about
almost like a plumbing system. We were just like, oh, there's too much fluid being produced and it's not being absorbed fast enough, so you have high pressure around your head. Sorry about the headaches. Like that was sort of the messaging. And now what you're describing to me is a much more intricate metabolic and endocrinologic milieu that's contributing to the condition.
Exactly, Heather. I think you got it. You got it.
Okay. Well, okay. And so how do we know who gets this condition and what role, as a general ophthalmologist, I'm interested for you to tell me as a general ophthalmologist, I'm interested for you to tell me more what role I can play in diagnosing this condition.
Yeah, so the classic patient that we see with IH is no secret to anyone. It's a woman of a childbearing age and generally has an excessive abdominal adipose tissue. That's your classic picture. And I think all of us, no matter what year we had our training in, can remember and understand that. However, I do want to mention that men and children can develop this condition, although it is much more rare to see it in those groups. So personally, when a man comes in and I'm suspicious of IH or raised intracranial pressure, it makes me think twice about diagnosing it as idiopathic. And I usually perform a lot more investigations. And specifically in men, sleep apnea is a lot more common than it is in women. And sleep apnea is a secondary cause of idiopathic or a secondary cause of intracranial hypertension. So that should be investigated, especially in men. And spinal tumors is another condition. There's been several case reports where men have been misdiagnosed with IIH or idiopathic intracranial hypertension, but indeed had a secondary cause where a spinal tumor was blocking CSF drainage as well. In children, IH happens usually around puberty as well. So we think the pathophysiology is very similar to what it is like in women of childbearing age. In prepubescent children, usually it's a secondary cause. So really rare to diagnose IIH in a child that's prepubescent. So that's sort of your classic patient. The second part to your question, which is, what role does a general ophthalmologist play? And as you know, I wear two hats. I'm a neuro-ophthalmologist, but I'm also a general ophthalmologist, and I see undifferentiated call patients that come in from the emergency room or family physicians who have not had an eye exam. And I'm often the first person to see their swollen nerves. So I think the main objective is for a general ophthalmologist is to perform a proper initial assessment and begin appropriate investigations. As you know, not in most of the jurisdictions in Canada, neuro-ophthalmology expertise can be hard to come by. So it's really important to expedite investigations as quickly as you can so that the neuro-ophthalmologist you're referring to can get a head start on treating these patients. So in terms of the main objective for a general ophthalmologist is really to rule out the secondary causes of raised intracranial pressure. And, what are those causes? And this will not be a surprise to anyone, but of course, the main concern is a space-occupying lesion like a tumor or hemorrhage. The second most concerning cause, I would say, would be venous sinus thrombosis because it's treated very differently from raised intracranial pressure of other causes. There are some other sort of easy to pick conditions that are easy to diagnose and pick out by a general ophthalmologist, like acute anemia, hypoparathyroidism, and of course, the medications that we know can contribute to IH as well.
And a reminder to all of us, every time we see somebody with those bilateral swollen discs, even though we don't like to do body medicine, you have to get out your blood pressure cuff and make sure your patient isn't urgent in the middle of a hypertensive urgency or emergency.
Absolutely. Yeah, I think that's a great point to bring up. My technicians know when somebody's main complaint is a headache or any
Mhm.
other neuro-ophthalmic complaint that they will perform a blood pressure, a height, and a weight for me to see the patient. So I
I
think it's
love
a
that.
great practice to incorporate when you train your technicians in the office so that it's already on the chart when you see the patient and you don't have to get them back to get those measurements done.
I love that. Follow us for more practice efficiency tips. That's perfect. Okay, so let's say we've done that basic workup. Are there other things that we should do in terms of imaging or investigations?
Yeah, and of course, that history, important history is coupled with, of course, an examination to confirm what you see. I think it's one of the most important things to do as a general ophthalmologist seeing these patients is to perform a urgent visual field assessment. Your urgency of what to do with these patients will absolutely rely on their functional visual field in their assessment. OCT is helpful, especially in the cases when the vision is down. As you know, most of these patients have very good central vision. And so often you will not know the severity of the disease unless you do a proper visual field. And sometimes if the vision is down, it can be due to some fluid or edema, macular edema that we see with severe optic nerve edema. And so ancillary testing is extremely important because that is really what we rely on to make a decision about how soon and how aggressively these patients should be treated. So one suggestion of mine is after doing ancillary testing, and if the patient's visual fields are not severely affected and have the classic finding of an enlarged blind spot in both eyes, would be to order some basic blood work while they wait for a neuro-ophthalmology assessment. I don't know if you have that, but I find that most practices have preset lab requisitions for things like uveitis or scleritis, and I find that's
Yeah,
not
I
necessarily the case
do,
with
but yeah, I don't have one for IAH. So tell us what should be on that list.
Well, I'm so happy you asked. I think it's really simple to set this up as part of your EMR. And specific labs that I would like to see on the requisition for IIH specifically is number one, CBC. So what I'm looking for there is raised, white count for secondary causes like meningitis or some sort of infectious cause. I'm also looking for anemia. I'll tell you, there is a case that I had in a young woman who had a quite profound bleeding through menarche and basically had significant anemia and came in with raised intracranial pressure and disc swelling. So anemia was corrected, and that's a secondary cause of idiopathic intracranial hypertension or intracranial hypertension rather. And she did quite well afterwards. So it's really important to get the basic blood work done. So CBC, the second thing that is important is INR or PTT for future lumbar puncture, because that will be coming. The next thing, of course, is creatinine EGFR for imaging purposes. These patients will all need imaging, as well as there are, kidney failure conditions that can cause raised intracranial pressure. And two others, which is parathyroid hormone levels as well as calcium levels. Hypoparathyroidism is one of the secondary causes of raised intracranial pressure, so it's important to include that. And in some cases, liver failure can cause this as well, so including LFTs on that is really important. So those are my recommendations. To review that, CBC, INR and PTT, creatinine EGFR, and then parathyroid hormone levels, calcium, and liver function tests.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Hi, I'm Alan Slomovic. I'm a cornea specialist from Toronto, and I listen to EyeCan podcast.
Let's jump to the imaging and lumbar puncture question here. So we will get to talking about like how do we help these patients and we're going to focus there. However, getting the diagnosis right, we want to make sure we rule out any other intracranial issues. And I think often when we see disc swelling, we want to just jump to that plain head CT or whatever imaging we can get the fastest, right? But my recall is there's some specific things we should ask for on that CT scan to make sure that we get the diagnosis right. Can you remind us of that?
Absolutely. Of course, the biggest danger we worry about with raised intracranial pressure is a space-occupying lesion. And that's a very time-sensitive thing. And so I absolutely relate to a lot of people who want to send somebody for a very fast CT scan that's plain CT that doesn't request anything else. However, as you may remember, venous sinus thrombosis is an extremely important condition to rule out. It is treated differently with the anticoagulation. And so we must know that indeed this condition is ruled out before we treat these patients or do a lumbar puncture. So whether you do a CT head or an MRI head, please always make sure that a CT venography or MR venography, venogram imaging is ordered. And you should always specify to the radiologist exactly what you're looking for. So I often like to write signs of raised intracranial pressure, rule out a space-occupying lesion, and specifically mention venous sinus thrombosis. And, also mention something about looking at specific signs of raised intracranial pressure. And we can certainly get into the details of that if we like, about the MRI signs of raised ICP that we see on imaging.
I don't know if we have time for all of those tonight, but I do want to talk about LP. Because I think lumbar puncture as an identifying, like how are we going to actually determine if indeed the pressure in the fluid around the brain is elevated? How are we going to know that? And how does LP tell us that?
I think LP is necessary to diagnose this condition. I will tell you that in some of our neuro-ophthalmology meetings, we have against and pro arguments about whether LP is necessary in every one of these patients. In my humble opinion, I really think it is, because it does rule out very important conditions like meningitis. And sometimes there is walking meningitis conditions that can cause disc swelling that present very similarly with headaches and debilitating symptoms. So I do think LP is necessary. In terms of sequence of testing, I do want to mention it is extremely important to perform imaging before one performs an LP. And this is for two reasons. The first reason, of course, is the brain herniation, which is a concern with a space-occupying lesion. So one must always know that the brain does not have any space-occupying lesions to herniate. And the second is post-LP, specifically on MRI imaging, we often see meningeal enhancement, which can complicate the picture when we are interpreting the imaging post-LP. So very important to do that. Now, how the LP is done is also very important. ICP depends on a number of factors you can imagine: breath holding, patient position, positive pressure that we see sometimes in overweight patients. And the ICP levels specifically are defined as measured in the lateral decubitus position with legs outstretched. And so it's really important to understand that whoever you're asking to perform the LP or whoever is doing this understands this. Very commonly, radiologists will perform lumbar punctures under fluoro, traditionally with a patient sitting up and bent forward. And so that is not necessarily a true measure of ICP levels. And that's important to keep in mind when we're interpreting the information that's given back to us.
Okay, that's great. So let's say we've got the results back from neuroimaging where there isn't any venous sinus thrombosis. Perhaps there are some signs of elevated ICP on the imaging that we have. And that LP that we've done shows opening pressure is elevated. Have we made the diagnosis? Are there ways that we can be certain and kind of take a list? How do we know?
I think that I'd like to refer to the diagnostic criteria for IIH. And historically, you may have heard the term dandy criteria. So the original criteria were defined in 1960. And as you can imagine, our imaging was not very eloquent at the time. So very basic neuroimaging. So the criteria incorporated the basics that we knew at the time. Then what most of our listeners, I think, will be familiar with through their residency training and their background is something called modified dandy criteria, which were used since somewhere in the 80s. And that's when the imaging became a little bit more defined and we could get more details. And we can actually perform venous imaging as well. Now, what we're using now is something called updated modified dandy criteria, and that's been in circulation for about a decade, about 10 years or so. And these diagnostic criteria incorporate the advance of neuroimaging and how that is very helpful in diagnosing IIH, and that includes very specific signs that we see on MRI, and those include empty cella, flattening of the globes, distension of the subarachnoid spaces around the optic nerves and the tortuosity of the optic nerves, and then last but not least, of course, the venous sinus stenosis. And those are the new sort of incorporated criteria in addition to the basic criteria that the dandy criteria identified.
That's fantastic. Thank you. Now, I want to talk about, before we jump into the treatment of this condition, could you take a moment just to walk us through, in my practice, when you see a patient, in particular an undifferentiated patient with headache, and you're trying to suss out, is this something serious? And tell us a little bit, what are their lives like when they have this condition and it's not treated? Does this condition matter? Your pressure is a little bit high around your head. Maybe your vision's affected, maybe it's not. I realize, of course, it's our priority to prevent vision loss. But my experience with these patients is that a lot of them are really, really silently suffering because they've maybe had a plain head CT for headaches and they've been told that it's normal, and that they need treatment for migraine, for example. So can you tell me, what do these patients look like in terms of their function? And then I want to get into how do we actually, how can we treat this?
I'm so glad you bring this up because I think this is really important to consider when you're seeing these patients. There is a lot of comorbid conditions that are associated with idiopathic intracranial hypertension, and they severely impact the patient's quality of life. And a few of those conditions are things that you already mentioned. For example, comorbid headache conditions like migraine or tension headaches. Those sort of things are very common in these patients, upwards of 50% plus. A lot of these patients have a very poor quality of life and visual quality of life, defined by the questionnaires that I used in research, all relating to, not just the headache and the disability that brings, but also to some of the visual symptoms. And IH often brings on dizziness or neck pain and back pain. And as you know, living with chronic pain is extremely debilitating. And another big one with these patients is depression and anxiety, and that should be managed along with their IIH and their headache conditions. So really important to, I think, come from both evidence and empathy with these patients because they truly are suffering in terms of their quality of life and their visual quality of life.
Okay, so let's get into it. How do we treat this? What are our options for patients?
I think the treatment needs to address two things. Our priority as ophthalmologists, of course, is to focus on their vision and their treatment. So in terms of vision, luckily, majority of the patients will have an enlarged blind spot with no associated peripheral visual field loss or central visual field loss. And so we actually have some time. So when I think about treatment, I think about treatment for vision, and then I think about treatment for headaches. And those two are quite important to differentiate between one another. There's something called what I call an IIH headache, which is, the headache that's got pulsatile tinnitus with it, with TVOs and all the visual symptoms and signs. And then there is premorbid headaches, which often are migraines. So about 40 to 50% of these patients will have about 85% of them have migraine, and about 25% of them have tension type headaches. And 50% of these patients self-medicate, right? And there's this entity called medication overuse headache. So if somebody's got a chronic daily headache and that maybe is related to raised intracranial pressure, they treat themselves and they take daily multiple doses of Tylenol and Advil. And they develop something called the medication overuse headache. And that's really important to identify. The second issue, of course, is the vision. So the first thing we traditionally think about when we think about IH is sort of it was weight loss, right? So, and I think if you're thinking about IH as equals obese and lose weight, you're living in a bit of an ice age, right? So it's not so simple anymore. And so when I talk to patients about treatment of this condition, I preface the weight questions and discussion with patients with something like this. So I'll describe to them what I think they have. I'll say, I believe you have a condition that's called idiopathic intracranial hypertension. I explain to them, we do understand what we do understand about this condition, that it is very complex and it involves increased production of spinal fluid and reduced resorption of spinal fluid. It is affected by multiple hormonal and metabolic factors. And part of these hormonal abnormalities have to deal with the weight collecting around our midline and specifically associated with a weight increase in a short period of time. So one of the key questions, I've learned in fellowship, and I use this, every time I see these patients, is I actually ask them non-judgmentally about what their weight was at the end of high school and what their weight is now. So often these are women of childbearing age who are maybe 10 years after the high school year. So it gives you a good idea without, judgment or, questioning what exactly we're looking at in terms of the weight gain and the risk factor there. And then I also ask them about the last 2 years, and there hasn't been a significant event which caused a significant weight change in their life and their body. And, I think, if you will, fat shaming is probably not helpful in these patients, and talking to them with understanding and empathy is extremely important. We do all know these patients have tried a million diets and a million exercise routines. It's really not that they're not motivated. One of the recent studies done by my colleagues, Dr. Delott, and her colleagues at the Kellogg Eye Center showed that the major barrier to weight loss in these patients is actually something called self-efficacy, or what they call self-efficacy, which is actually a belief in that one can reach a goal weight or a particular objective that they have. And majority of these patients have identified that they do not believe that they can achieve their goal. So that's really important to understand, that it doesn't come from lack of motivation. It doesn't come from a lack of trying, but this is a very complex hormonal condition that we need to consider all aspects of in order to encourage changes. And one thing I will say, so, there's a lot of recent sort of diet fads. I don't know have you tried intermittent fasting, Heather, or have you ever?
Oh, I have done. If there is a fad out there, I have tried it, but I can't intermittent fast. Like, starvation will never be a problem that I have. And even going from like late at night till, I don't know, middle of the day, I'm like, what is happening? So no, not successful. No intermittent fasting for O'Donnell. But tell me, does this work for these patients?
Well, the reason why I bring this up is because I actually want to caution, people against intermittent fasting, specifically in this patient group. So there's some, low-level evidence case studies have been done on patients with IH who go through Ramadan, where they fast for an extensive period of time. And it's actually shown that it exacerbates IH symptoms. And the thinking there is that the GLP levels, which are lower when you fast, they actually upregulate CSF production, which can actually worsens intracranial pressure. And so it's not important to lose weight. It's important to know how to lose the weight specifically in these patients, and that not every diet or every approach is helpful here. So going through proper channels is really important for these patients. Like I said, evidence and empathy is how you should lead with these patients. Since I started practicing, there's been a surge of clinics specializing in obesity and bariatric medicine. Those have experts, internal medicine experts and surgical experts who manage these patients and care for these patients. And there are some universities that have created programs specifically to do with obesity medicine because of the epidemic of obesity that we've had across North America. So weight, of course, is one of the discussions that has to happen, but it's really important that we consider how we talk to these patients about it.
I think that's such an important and powerful point. So thank you so much for emphasizing that. It's one of my sort of professional soapboxes to create space in medical communities where we don't fat shame our patients. And, in my practice, it's policy to just ask each patient if I have a medical reason to discuss their weight, to simply ask their permission. May I have permission to discuss your weight today? It was a hot tip from Ali Zentner, who's an obesity expert here in Vancouver. And it has been a game changer for the comfort that my patients have with discussing this problem. And for many of them, it's not a problem. But in IH, we know it can have an impact. You mentioned GLP-1, and can you tell us about how, I know there are other medical therapies, but how have GLP-1 medications like Ozempic changed the treatment paradigms, or have they changed treatment paradigms for IAH?
That's a great question. What a hot topic it is right now, right?
Yeah.
So, I think I would say with GLP-1 medications, we're still collecting some data. This is a small, a population of patients who have IIH, but I do believe it's going to make a long-term difference looking at some of the preliminary data. So the answer to whether GLP is helpful for IH, I think, is a yes. The one study I can think of that was done in 2023 administered GLP medication. The one that they used is called exenatidine, and the ICP was actually lowered by about 5 centimeters of water, and that maintained at that lower level up to 12 weeks. So we'll have to see how this translates to the symptoms. So this is sort of a physical measure to tell us that it does cause lower intracranial pressure in these patients, but we still don't understand exactly, how the headaches and their symptoms will be impacted. And actually, in that small subset of patients, which is about 16 patients, I believe, in that study, it didn't really show that the headache symptoms improved despite the reduction with ICP. So it's, certainly complex and still requires a multimodal approach to treating these patients, but it shows great promise as it has with insulin resistance and weight loss in the diabetic populations, for example.
Okay, that's so helpful. Tell me about, I want to talk about venous stenosis and this element of the potential, like a physiologic or a structural change that may have intervention. So can you tell me anatomically what vein is stenosed? Where are these stenosed veins? And can we open them up and solve a problem here?
Oh, it's such a hot topic, very close to my heart. As I mentioned, this is the research project I focused on early on in residency, and I'm just so glad to see that a decade later we're seeing some progress of that research in the field developing. So before jumping into venous sinus stenosis, I just want to mention I do find there's some confusion about venous sinus thrombosis and venous sinus stenosis, and I do want to sort of
Yes.
draw some differentiation there. So venous sinus thrombosis is basically a clot in the transverse venous sinuses, or any venous sinus actually, and it blocks venous drainage, and that of course compromises CSF drainage and circulation. And that is treated by resolving the clot, which in simple terms is anticoagulation. Now, venous sinus stenosis is an imaging finding that we've developed our neuroimaging techniques and the MRI and MRV became more accessible and easier to do and easier to interpret, we've noticed that the patients with raised intracranial pressure for idiopathic reasons have this thinning out or narrowing of the transverse venous sinuses, and often it is bilateral. Okay, so if you look at the general population, about 2% of the general population, normal population, will have venous sinus stenosis and don't have IH, right? Almost universally, we see venous sinus stenosis in IH, and it's commonly bilateral, most commonly bilateral. So to talk about this condition is important to sort of differentiate between two kinds of venous sinus stenosis. One form is called the intrinsic form, and one form is called the extrinsic form. And the intrinsic form is related to within the vessel problems. So those involve swollen arachnoid granulations in the sinus, the septal bands that are formed between the walls of the vessel. There's some anatomic variants that are just narrowing of the wall. And you can imagine those intrinsic forms are the forms that are most likely to be responsive to stenting, right? So there is a physical barrier, the vein is narrowed, we open up the vein with stenting, and that sort of helps the process along. The extrinsic form is this gradual narrowing of the vein that actually reverses with normalization of ICP. So it's not a structural cause in the wall, but rather an effect of raised ICP on the wall itself. And so those two differentiations are really important. So for venous sinus stenting, which has kind of gained a bit of popularity recently, specifically we use it for medically and surgically refractive patients who struggle with raised ICP despite our best efforts. We have to show that there is a gradient across the stenosis. So we have to show that there is, pre-stenosis to post-stenosis and draining, that there is indeed a pressure gradient. If there's no pressure gradient, it's not very useful to stent. To stent it, it's not going to help us.
Okay.
So things, that we worry about with stenting, and the reason why we don't do it willy-nilly in everybody is because it can be complicated. So you can develop stent thrombosis, right? So now you're asking for extra trouble with CSF drainage. You can develop subdural hematomas. The stents can migrate along the wall. There has been deaths reported with this condition. So, it's not a benign thing to do, and it's certainly not our primary method of treatment because it can cause significant morbidity and mortality. And although it does, show some of the meta-analyses recently done show that there's improvement in the main symptoms, especially the kind of visual symptoms and some of the pain and the dizziness, the headaches are helped least of all. And so again, not a, panacea for all treatment for all of the symptoms, but it's a tool in the armamentarium for this challenging condition for us to treat. And I think it's really important for us to understand that this is another method that we can use for these patients.
Anna, that is such an amazing review. You've given me so much new information as well. And actually, I love that this has been a bit of a game-changing conversation for me personally, just thinking about this more metabolically as opposed to a structural phenomenon. So that's incredibly helpful. Before we let you go, it's really one of the things that we like to do on the EyeCan podcast is get to know our guests outside of the world of medicine that we spend a bunch of our time in. So tell us, now I know a bit about you because you're a colleague of mine here in Vancouver, but tell our listeners, what do you like to do when you're not doing this amazing neuro-ophthalmology work that you do and other comprehensive ophthalmology work?
Oh, well, thank you so much. I mean, not too commonly in my professional life, I get asked questions like this, and I love talking about this. I think it's so important to have a sort of a secondary focus in life. I think it's so important to have, post-professional life, some other things that define you and not just our profession. You're an amazing advocate for your patients and you're an amazing ophthalmologist, but I also know that you prioritize other important things like family and other interests in your life. And I do think that's important. So for me, actually, I'm looking at a wall in front of me, and I'm not sure if you're familiar with a quote. It's "Pressure is privilege." Have you heard that quote before?
No, I haven't heard this.
Yeah, and another quote I have in front of me is "Start where you are, use what you have, and do what you can." And that both of those quotes are actually from The first one is from Billie Jean King, who was a tennis player, a female tennis player.
King. Yeah.
Arthur Ashe. So one of my passions is tennis. So I actually love playing tennis, and I have 2 kids, and I think they're just as obsessed with tennis as I am at this point. They're 3 and 5, and we watch tennis tournaments on the regular and play tennis together. So really, really one of my passions. Education is another passion. You've mentioned my involvement with the SFU Medical School, and that's been a big project of mine over the last year and a half, and had taken up a lot of effort. Some other interests I have may be surprising, but I love interior design. So you'll see me reading magazines on how to design spaces. I think it's really important to have function.
That's a very cool hobby.
Yeah, so
it's great.
My big interest too.
I am probably one of the worst tennis players in the world. And when I was in my undergraduate degree, I had to take a tennis class. And this was at a time where I was very generally pretty academically oriented. And my tennis teacher, tennis professor, if you will, in university, gave me a B. And I was furious. Okay, look, if the listenership happens to include Tim Hopper and he's going to get slammed by this, I'm okay with that. You can throw some shade his way. And I was like, come on, I got perfect in every assignment. My exams are exceptional. I understand the rules perfectly. And he was like, Heather, you're the worst tennis player that's ever taken this class. And through the entire semester, you did not improve. While you were a very keen student, I cannot give you an A. So I'm in awe of people who excel at tennis. That's a very cool hobby you have.
I'll tell you one key reference for listeners. So if you look at the athletes who live the longest out of all the wonderful sports out there, any racket sport specifically means a better longevity for those players. So I think it's about sort of using your brain and your muscles, and it's go and stop, and so no matter how good or bad you are, it's dynamic. Yeah. So no matter how good or bad you are, I think you should continue to play, because
I'll stick to the squash and pickleball courts myself.
Well, you know what? Any racket sports. So I think you're good there. So,
Dr. Neufeld, thank you so much for being here. We appreciate your time, your generosity with your intellect. Thank you so much for coming and joining us tonight.
Thank you so much, Heather and the team, for inviting me today, and for being such amazing advocates at the national level for our profession. And thank you for bringing this condition to the forefront and using this podcast as a means to do it. I really appreciate it.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months. EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca, et nous essaierons de les intégrer dans les prochains épisodes.
Season 5 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado EyeCan vous est offerte par Bayer. Nous les remercions pour leur soutien.
Thank you from the Canadian Ophthalmological Society. EyeCan is available wherever you listen to your podcasts, and of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.